The way I have mine set up, everybody can set up their virtual lens the way they want that suits their practice. The way I have it set up, at least for now, is I have a distance option with astigmatism present, showing the blur from astigmatism. I have it with astigmatism corrected, near with astigmatism present, near with the astigmatism corrected, intermediate with the astigmatism corrected. I've kept that a little simpler, and of course, a trifocal, and of course, with astigmatism corrected. In my practice, I don't use EDOFs. I'm so happy with the trifocals. If I'm going to go with someone for a greater range of vision or for a simultaneous vision IOL, and I'm going to go for a trifocal. So here's an example. This was a lifelong hyperope plus 150 with astigmatism. He's retired. He wants spectacle independence. Never tried monovision, very skeptical. Oh, it's a lady, sorry. She's at about 64. I showed her distance without astigmatism corrected, distance only with astigmatism corrected, intermediate and the non-dominant eye, and the trifocal. And she looked at the glare and starburst profile and said, that's very tolerable. I really like the fact that I have the full range of vision. She chose the trifocal and she loves it. She sees the glare and starburst, but she wasn't bothered by it. So she felt very comfortable that what I showed her reflected what she was seeing in it and with her daily experience with her trifocal. And the way to do that with virtual lens, primarily, especially for the patients, to show them a nighttime scene with street lights and with car headlights. So here's a golfer, wants spectacle independence. He had never tried monovision, and I showed him these combinations: distance without astigmatism corrected, um, with it corrected. He clearly saw the benefit of correcting the astigmatism. Intermediate in the non-dominant eye, kind of intermediate or near, and he really saw the benefit of that, like looking at a scorecard, for example, looking at the course outline. Um, so I showed him the trifocal, and he was really did not like the glare and starburst. And so as a result, I did mini monovision, and he loves it post-operatively. When I do that, by the way, I always try to do the non-dominant eye first. If the calculations are kind of questionable, but if I'm comfortable with the calculations, I'll do the dominant eye and hit plano, hopefully. And that way we have the comfort. If the distance is good, we can do the mini monovision. So here's a hunter. You can tell I live in Texas. He'd never been told he had astigmatism, so he's very skeptical. He's very comfortable with reading glasses. He wanted to hunt very clearly, see at a distance, hunting birds. Um, I showed him distance without astigmatism and distance with it corrected, and he really saw the benefit. Um, he did see that there was decreased near in both eyes. I pointed that out to him, and so he was aware of that, but he loved the distance vision he saw. And he was just concerned that he wouldn't like the intermediate, didn't want to do a trifocal. He wanted the best vision day and night, and he loves both eyes with distance, with astigmatism corrected. So the benefit for this patient was educating him about the astigmatism, about the distance correction, and what the trade-off is. Here's a myope who's an attorney, -3, works in the office without glasses, tried monovision contact lenses, hated it, but he insisted he wants distance vision in both eyes. He's still a practicing attorney. I showed him the distance. He saw the blurry near with that. Kind of surprised him. So many patients who are myopes think that if you correct them for distance, they're still going to retain their near vision. So this is really valuable to show them how this blurs the near. Pardon me for my cough here. Um, the intermediate near, he felt very comfortable with that. I didn't go with -3. I went for about something equivalent around -150. That's why it's intermediate at near. And he didn't want any glare or starburst. So ultimately, we did both eyes for near. He loves it. He's comfortable. He goes to the office, takes off his glasses, and works comfortably all day. And he reads at home at night and works on the computer without glasses. Here's an engineer, -5. He wears contact lenses for distance. He didn't like monovision. He does read at night without glasses. and he insisted he wants both eyes for distance. I showed him again the distance. He saw the blurred near, like he saw with his contacts. I showed him the intermediate and near, and he kind of liked that, but he still wanted some distance. Didn't want glare starburst. So I did mini monovision with him, plano and -1, and very happy. Now, I have several other patients who've adopted trifocals because it make it sounds like nobody wants to do trifocals, but I wanted to show you some of the nuances of other refractive combinations. And here's one final one. This elderly woman, 2 diopters of astigmatism. She loves her glasses. They cover my wrinkles. I showed her distance with astigmatism corrected, with it uncorrected and corrected. She saw the clarity, greater clarity. Showed her intermediate with astigmatism corrected. I showed her the trifocal. She didn't want any glare starburst. And ultimately, she chose no toric. And she said she's going to be happy wearing her glasses. But the benefit here is I was able to educate her and her family about the fact she was going to have blurred, uncorrected vision, and she was not to expect that with the choice she made for a lens implant. So, no matter what you end up choosing for the patient, by giving them this kind of very remarkably real life simulation, it really, I think, enhances their understanding of what they're choosing. And John used the term empowered. It really does. I think it really empowers patients to make a choice. And if the family's in the room, even better, because they then can hear the patient describe the experience and make the choice, and they can reinforce that later on.